Thank you again for coming tonight. Hopefully you'll find what we have to discuss informative. What I will do is go through the presentation and we can play this by ear. If it seems that we're still able to clip along taking questions as we go, why don't we plan on that? So if a question does come to mind, why don't we just go ahead and do that? And if it seems that we're slowing up a bit, maybe we'll table them until the end. But what I'll be discussing this evening is a newer approach to address some problems in the spine in the neck or the cervical region of the neck in a minimally invasive fashion. Not all problems of the neck can be addressed in this fashion, but many of them can, and we'll discuss that along the way. Now, it's very important for you to know that, of course, I do have conflict of interest in giving this talk. First, it's important that you know that I get paid when I operate. That's probably self-evident for anyone hearing a doctor give a talk, but I want to highlight that fact. Additionally, I am one of the inventors of some of the instruments and implants that I'm discussing this evening, and it's important for you to know that as well. That introduces a potential financial bias into decision making, and it's always important when a person's hearing a presentation of this type that they're aware of that. So I just want to make sure that you do know that up front. So, a common problem that I will face in my practice as a neurosurgeon is a pinched nerve in the neck. A pinched nerve can come about from any of a number of problems, but most commonly from a form of arthritis or spondylosis, as we call it, when that degenerative arthritis affects the spine. When the arthritis affects the spine, people can develop a condition called spinal stenosis, which means a narrowing when a bone spur forms that can pinch a nerve. Another common cause of a pinched nerve in the neck is a herniated disc, or some people will sometimes refer to this as a ruptured disc. In the diagram you see here, in the circle on the left, you can see a herniated disc. In the picture on the right, what we see is that same herniated disc right here. Now, is my arrow showing up? I'll try to wiggle it so you can see it a little better. But this is the herniated disc on the other picture. When we treat these problems, first we always want to try conservative measures, that is non-surgical treatments. This talk is not about those treatments, but I do want to emphasize that we first try to treat these without using surgery. When those other treatments, such as physical therapy, medication, steroids, traction, don't work to alleviate the person's symptoms, we will then have to do surgery, often. When we do surgery, we're seeking to address the pain, whether it's in the neck or running down the shoulder, arm, and hand. Our goal is to improve function for the patient. If they have weakness, we want to improve that. If they're having numbness or tingling, we'd like to make that go away. We would also like to do all of this while allowing the neck to still be strong enough to support the head. Or in other words, we need to have a spine that will continue to be strong enough to allow the support of the head. We also want the neck to be as mobile as possible. It's designed to move. We'd like to keep it that way if we can. We're going to go through a little history of how we've tried to treat this over the years, and we'll do this quickly, but I think it's interesting. Back in the 1950s, when surgeons started to approach these problems, they did start to realize, looking back even earlier into the 30s and 20s, that treating ruptured discs in the neck, like we did in the lower back, didn't always work as well. In the lower back, we are operating often below the level of the spinal cord, and so we can come from behind and safely move to the side of the sac where the nerve root bundle passes. In the neck, if we try that, it doesn't work. We can damage the person severely by injuring the spinal cord. This was discovered pretty early on, back in the 30s and 40s, when initial attempts at treating disc herniations in the neck were underway. Today, in some situations, we can operate on herniated discs in the neck coming from behind, but over 70% of cases really don't lend themselves to that, and that's why we're talking about going from the front. This is a picture of what happened after a person had a 2-level discectomy. The bones in the neck are numbered. Here's the second bone. The third has a number 3. Here's the 4th, the 5th, the 6th, and then the 7th. You'll note here that the spine partially collapsed in the front, and that's one of the challenges that came up when the initial approaches were being done from the front, when the entire disc would be removed to get access to the bone spur or the ruptured fragment. If the disc was removed and nothing was put in its place, the spine would partially lose its height in the front and collapse over. And pictures like this one is a result of that. The other thing I'll point out is that this spine curves arching forward. That's not how it should be. It should arch backward. So this resulted in what we call a kyphotic angle and pain for the patient. The next stage in the development of surgery on the neck from the front was doing a fusion procedure, but without using either a plate or screws. That is a procedure that usually works very well, but in some cases the bone will not grow together. Also, in other cases, the spine will have a tendency to straighten. We'd rather see it bowing forward slightly because it can act as a spring more effectively in that curvature. And also, patients with this treatment would need to be in a collar for often 3 or more months to get the bone to heal properly. So the next generation of the procedure was to use a plate and screws. This continues to be a very commonly performed procedure. We have a higher fusion rate. We're able to better maintain the desired curvature in the neck, which is associated with a lower risk of long-term neck pain. And when we're using a plate and screws on the inside, especially with a 1-level procedure, we often don't need to use a collar on the outside. The plate and screws does the job. Over the years, the technology of the plates and screws has really progressed. And I'm showing you here multiple examples of different companies' versions of the same thing. Up here in the upper right, you can see a plate that has 1 screw per level, whereas all of these other designs have 2. This plate system has a unique locking mechanism. This one doesn't have a plate at all, and it's really a plug with screws going through the plug so that nothing sits on the front of the spine. And over here is a plate system that is totally reabsorbed. So again, this is an area where there has been a lot of innovation by companies who work in this space. But this solution isn't perfect. What can happen? Well, sometimes we'll develop bone spurs at the end of where we place the plate. And you can see one depicted here at the white arrow. It might be a little hard to see, but just look at the top of the plate, and you'll see a little bone spur that has developed on the front of the C3 bone in this case. Also, we're concerned in general about degeneration at the next level. We'll sometimes call this adjacent segment disease. It's thought that about 2.9% per year, that the incidence of this occurring is about 2.9% per year. Here we're seeing 2 versions of the same neck separated by 9 years. 6 weeks after the surgery, in the image of the left, you can see the plug, where my arrow is moving right now. Levels above it and below it certainly look healthier than they did 9 years later. Here, the level below has an ample height to the disc. Here, the disc is much decreased in size, and we see bone spurs on the front and at the back of the disc space. Similar degeneration, but to a lesser degree, has occurred at these spaces as well. If we look at this systematically, we find that 92% of patients after a fusion have degeneration at the next level at 5 years. So I guess the question, though, and I'll stay here for a moment, is, so what causes that? We're not entirely sure. One thought is that the fusion itself puts more stress on the level above and below in the spine after it's placed. similar to a chain where you weld together a few links will have greater level of wear on either side of where you weld the links together. It's thought that by putting extra stress above and below a fusion, we're accelerating degeneration. But even though that may be seem intuitively obvious, the counter argument to that is that if you were to take a group of people who have a procedure who are, say, age 40, and let's say none of them have gray hair, and you look at them 9 years later, you might find that 92% of them have gray hair. Well, these people age. And are we seeing a manifestation of the procedure itself, or are we observing what we'd call natural history? Is the patient who has a disc herniation at age 35 or 40 more likely to have subsequent disc herniations in their life than someone who never did? The answer is yes. Is the person who has arthritis in their neck at 35 or 40 more likely to have arthritis in their neck at other segments as well 10 years later? The answer is yes. And so what isn't really clear to us, even though we see this degeneration down the road, is the extent to which this is being caused by the fusion or the extent to which this is being caused by natural history. Nonetheless, we're concerned as doctors. Our job is first do no harm. And if there is a chance that what we're doing is bringing about greater wear and tear at the next levels, we'd like to do what we can to lower that additional wear and tear. And so, one question is this the answer? An artificial cervical disc. When we do a fusion, we take away movement at that level of the neck permanently. So, what if we can get the bone spur out or the disc herniation out, but allow the person to continue to have movement in their neck? This is one way that surgeons have tried to answer that. Let's take the whole disc space out, but instead of fusing the spine across that level, let's put in a device that will allow the neck to continue to move. These are the 3 artificial cervical discs that are presently approved by the FDA, Food and Drug Administration, for general use. We'll just leave it at that for now. But this is one technical solution. So, are we there? Are we done? Is the artificial cervical disc really the end of development for taking care of problems in the neck? Or are there other things we can do to continue to improve? We are able to successfully address pain, especially arm, shoulder, and hand pain for these patients with a success rate over 90%, often 95%. We're able to improve function. We're able to maintain stability. We're able to maintain mobility. With the artificial disc, we may or may not be able to reduce adjacent segment disease. We're still not sure how real that is. We're still not sure if the artificial disc will allow us to do that. But, it's still not perfect. It's an artificial object in a person's body. And if we're putting it in at age 40, are we going to be taking them out at age 50 or 60? Patients who have the cervical disc still take about 4 to 6 weeks to get back to work, and sometimes longer if they have heavier physical jobs. As is true for most spinal procedures, people who have office-based jobs can get back to work earlier. But what if you work construction? What if you do material handling? What if you're on a road crew? It takes much more time to get back to work. We'd like also to be able to eliminate the collar, and sometimes when cervical discs are replaced, we will still use a collar. I think it's also reasonable to ask the question, do we really have to take out the whole disc if the only problem is a little lump that's ruptured at the back end? And so that gets to a newer approach, and one that other surgeon groups have been working on, and I have as well with a great team. Can we go about this in a completely different way? I think we can, and I'll show you some data on patients, and I'll describe to you what we're up to here. We're calling this a TransCorp procedure, or TCMD is the fuller name, transcorporal microdiscectomy, or TCMD. And the idea here is, instead of removing the entire disc shown here in red, what if we leave the disc space as it is and let the patient continue to move using their natural disc, and instead drill a channel obliquely through the bone? This, in the lower picture, is a depiction of a hole we might make in doing such a procedure. So rather than removing the whole disc and needing to put in either a disc replacement or a fusion to basically heal the defect, we can drill a channel in an oblique angle, as depicted here, and get access to the bone spur or the ruptured disc fragment. So what is this? TCMD, or transcorporal microdiscectomy, is a novel approach that does not require removal of the complete disc. We let the patient keep it. By doing so, we don't need to do a spinal fusion, and we don't need to do an artificial cervical disc. We are able to achieve excellent pain relief in patients who are eligible for this, and again, not everyone is. For many patients who have this procedure, we're able to do this as an outpatient, and we're also usually able to get patients who have this back to work in days, not weeks or months. When I looked back after developing this procedure, and again, other groups have done a variation on this, and I'll show some of their work in a few minutes here. But when I started looking back at my own experience, I wanted to find out, after starting to do this procedure, whether or not we really were helping people. And so when I looked back at my own series and offering this to patients, I asked the question, what percentage of my patients who have this procedure have any neck or arm symptom at all, even if it's a minor annoyance, whether it's a minor annoyance or severe? How many of my patients have any neck or arm symptoms that they're reporting at the 3-month mark? And what I learned, that 7% of my TCMD patients were, and my ACDF, or anterior cervical discectomy and fusion patients, 18% of them were. When I asked the question if they were having any neck pain whatsoever, at 3 months I found that 5% of my TCMD patients were having pain, and 14% of my ACDF patients were still having some pain. When I asked the question radiating pain, and by that I mean shoulder, arm, or hand pain, I found that 5% of my TCMD patients were having some radiating pain, and 8% of my ACDF, or neck or fusion patients, were having some pain. Another way, radiating numbness or tingling, another symptom patients can report. I found that 2% of my TCMD patients were still having this at 3 months, and 4% of my fusion patients were. So it seemed, as I was looking at this, as though we were getting good results, certainly as good as a fusion. Again, everyone can't have this, but for the patient who's a good candidate for this procedure. I had, of course, been looking at the medical literature along the way, and I came upon this as a variation of an earlier procedure that I had learned in training, and that had mostly fallen out of favor, and this was a less invasive way of that approach. But, you know, I was following also what other groups were doing, and are other people using similar approaches? And the answer is yes, and also safely and effectively. This is just the first part of the portion of the abstract of a group in Japan that published on their work in 2009. This is a part of the abstract from a Korean group that had published in 2007. This is a portion of the abstract of a group in France that published in 2009 as well. And there are others also. I just wanted to show a few examples. So, with this approach, making the channel and fishing out the fragment or the bone spur through that channel, are we there? I mean, is this really going to be the definitive procedure? Not convinced. Couple of questions, and I think there are really 4 criticisms that I've heard, or concerns about this procedure. One is a question of whether or not we can adequately protect a very important artery that travels right alongside the spine. So let me just show you here that there is an artery that is not shown on these diagrams. These are designed to show bone, but there is an artery that travels in a channel in the spine right to the side. One concern is, can we do this procedure and reliably know that we are not going to damage that artery? It's an important artery. It supplies the brainstem. We need it. A second concern was the level of technical difficulty in the procedure. If you're the kind of person who thinks it's interesting to put together a ship in a bottle, doing an operation like this through a 6mm hole is interesting. If you're not that kind of a person, and if you're a surgeon who does this all the time, you might find this to be overly tedious. A third question and a fourth question are both shown on this diagram. One was, what happens to the hole over time? On the left, you can see an image showing the hole as it was created immediately after the surgery. On the right, you see this hole about 6 months later, and it hasn't fully healed in this example. This raises a question. How often will that hole heal? Additionally, if you look closely at the height of the disc, the cartilage pad, here under the hole and here under the hole, you may notice that it's shorter 6 months later. That raises a good question. If you're doing this procedure, to what extent will you damage further the disc below it? How would you damage the disc? Well, one, by entering it and causing swelling and inflammation from the dissection. Two, when you're making your channel, are you going to deprive that portion of the disc of a part of its blood supply, and will that lead to it to degenerate further? Three, there is an important structure in the spine, shown well on this diagram, that you must preserve. If you don't, the spine will degenerate at that level. We call this structure the oncovertebral joint. Now, if you consider what the spine looks like in the lower back, the discs are flat. They're like pancakes. If you look at these discs, however, they're not. They're sort of like, smiley faces, if you will. There is a projection of bone that goes up on the side. One's here and one is here. One on the left, one on the right. And sort of an oversimplified way of thinking about that is that this is one way that the neck has of not slipping side to side. In the mid portion of the spine, the thoracic region, or the lower portion of the spine, the lumbar region, there are structures in the body that are farther away from the midline than the spine. In the mid-back, there's the rib cage. In the lower spine, there's the pelvis. And all the muscular attachments to these other structures help prevent the spine from slipping side to side, if you will. It's more complicated than that, but this is a simplified version. In the neck, those projections upward of bone at the sides help allow the spine to not slip side to side. Again, an oversimplification. But after bringing up that point, I just want to emphasize to you that if this procedure is done in such a way as to not protect the mechanical integrity of that structure, what we call the oncovertebral joint, or UVJ for short, if we don't protect that structure, ultimately that disc will gradually degenerate further, and the person could ultimately end up with a fusion. So after thinking through all of this, a talented team that I've been working with and I got to work on this, and we came up with a number of different solutions. We asked a number of questions, and we've done some research on this. First, we needed a better way to make sure that we could do the procedure reliably every time. I want the channel to be positioned so that, one, I don't get close to the vertebral artery. Two, I want to be able to get to the bone spur and the disc fragment every time. Three, I have to protect the mechanical integrity of the oncovertebral joint. Four, I have to minimize any intrusion into the disc space itself. How do we do that? Well, we stopped doing the procedure freehand, which is how I had been doing it up to that point. The way that we do this now is with a precise guide, under X-ray guidance whenever possible, under direct vision always with the microscope. We attach a guide that allows me to drill the channel in a very precise manner. These are just some intraoperative pictures of what the guide looks like. This is the base of the guide, Here is the shaft that we drill our hole through. It's long by design because you can imagine a rifle is more accurate than a pistol. We make this channel quite long so our drill channel will be very accurate. This base here is a structure for an anchoring pin, and here in the middle picture you can see the anchoring pin as it's being positioned. And in the final shot to the lower right, the anchoring pin head is right here, and now the device is fully secured to the spine, and this is anywhere from 12 to 14 millimeters long, and so it certainly has enough bite into bone to not allow this to move. And here's the channel through which we can then drill. We wanted to find out if an approach similar to this would maintain the stability of the spine, and we've learned that it does. We learned that by studying the procedure in cadavers. We asked the question, if we drill this channel, do we or do we not lose the stability of the uncovertebral joint? And we found that we don't. Another important part of this work has been finding a way to get that hole to fuse reliably every time. And by fuse, I mean we want it to heal. I should be careful. The goal, again, is not to fuse two bones of the spine together. Our goal is instead to get that hole that we drill through bone to heal. We want bone to fill that hole once again. The way we do that is using this device, which is hollow. I think that's probably easier to see here. This end is closed. This end is open. It's tapered as well. Why is it open on one end and closed on the other? Well, it's closed on the back end because we don't want any graft material that we put inside of this device to migrate backwards and irritate the nerve root. So we closed off the back end. The front end is open so that we can get the bone graft in. We need a way to introduce it. It's tapered, as you can see better on the picture on the left, so that it will never move backward toward the spinal cord and toward the nerve root. It's made of a material called beta tricalcium phosphate, which has been used in over 800,000 procedures worldwide, and it is FDA cleared for use in the spine in these non-load-bearing applications. So how does this approach then differ from what other people are doing? Well, one, we preserve the uncovertebral stability, and the other groups, I think, that have been working on this have probably paid less attention to that important fact. Secondly, we're using a precisely guided approach. This is reproducible, and we can get the desired trajectory. We're not doing this in a freehand manner, as are the other groups who have been publishing on this. And then finally, we are repairing the access channel so that over the long term we'll be able to restore to the spine the full strength, especially of the front wall of bone, which is most important when a person is bending forward. So how exactly do we do this? Well, first we open in a standard fashion. Then we place in a precise manner our guide. Here is an intraoperative shot of what the guide looks like in place. I've already shown that. Here's an X-ray image of the guide in position, and here you can see the drill descending down to the desired target. When we use the drill to make our 6 millimeter channel, we keep the graft, and our drill is specially designed to do that. Here you can see, if it looks a bit like a barber pole, the red is the bone graft, or the bone marrow, if you will, that we keep when we do the drilling. We then use our hole to get access, and here's a picture of the hole, to get access to the disc fragment that is herniated or the bone spur. We get that away from the nerve root. And then finally, down here, I have an intraoperative picture of there we go, waiting for my mouse. Right here, you can see on the outside, the white is the beta tricalcium phosphate, and in the middle is the bone marrow that we're restoring to that space. Why not just put the bone marrow in directly and leave it? Well, it could either fall out the front side, in which case it wouldn't be there to do its job, or potentially it could migrate backward and irritate the nerve root. We don't want to take that chance. These are close-ups of some of those same pictures. So again, in the upper right, you can see here you can see the shadow of the anchoring pin, and then here is the shadow of the drill on its way back. Again, a closer shot of the graft material on the drill. We create a channel. Here you can see it obliquely coming downhill. That gives us access to that space. And again, the lower left is a pretty good picture looking down the barrel of the channel. After we make the channel and take the material out, and get the bone spur or disc fragment out, we then use a reamer. This does two things. One, it ensures at the end of the procedure that we have a precise, a somewhat conical shape to the channel so that it will fit perfectly the implant. The implant is positioned, as you can see in these pictures as well. Again, lower right, we have a picture of what that looks like after it's in place. And again, that will be gradually reabsorbed over about a 3 to 6 month period of time. What you would see, if we were able to show you, is first in this area, I have a hemostatic agent that you cannot see well, but I can, right up in here. This is not bone. That material, after I remove it, would show you the channel. Then I'm fishing out a fragment of disc material through that 6 millimeter channel, and then I'm showing the plug being situated and inserted into place after the reaming. So it's, basically with movement, what I've already shown you in still pictures. And if anyone's really curious, I can show you on mine later. So again, what's different about this? I'm going to hammer this point home because it's the most important part of the procedure. We're not destroying the disc tissue. We are getting the ruptured fragment out while preserving the rest of the disc. That's how we treat a disc herniation in the lumbar spine. Every time a person has a ruptured disc in the low back, we don't do a fusion. That's more the exception than the rule. In most situations there, we remove only the ruptured lump, and we allow the person to continue to have movement with their natural disc. And over the course of a person's lifetime, that's successful in the low back, where there's much more stress on the disc, 90% of the time. We are coming in through this channel that comes obliquely at a downslope through the front of the spine, and again, saving the disc space. So why do it this way? Well, because we can preserve motion, and we can do it without having to require of the patient an implant that may or may not last the rest of their natural life. We're hoping that to the extent that adjacent segment disease is real, we are hoping that allowing continued motion with the natural disc will lower the risk of that being an issue. But as I pointed out earlier, there's still a lot of research to do in that area. Why do it this way? Because patients can typically return to work in days, not weeks or months, and I'll show you some data, early data that I have on that. They also typically have much less pain with this procedure. Now, let me say that a cervical fusion from the front or a disc replacement may sound like very painful procedures. For some patients they are, but for most they're not. Pain is not usually a big problem for most patients who go through these procedures. But this procedure, the transcorporal microdiscectomy, is even more comfortable, and I think that's one of the reasons why we're able to allow patients to go back to work so much more quickly. Instead of having a graft inserted between two bones, we have a plug that's placed into one solid bone. And so we don't have, this motion where there's a little bone grinding on bone while we're waiting for the healing to be completed. So again, we're able to get people back to work more quickly. Another benefit of this procedure is that it can be used right next to a fusion procedure, as this picture shows. The circle shows you a plug, a transcorporal microdiscectomy plug. Below that, you can see the side shot of a plate and screws. Without the transcorporal microdiscectomy procedure, this person would have had a 3-level fusion. But because I was able to incorporate this procedure, I had to take motion only at 2 levels. So it gives us greater flexibility. I would love to have been able to do the TCMD procedure at all 3 levels for this patient, but they were only a candidate for it at one of the 3 levels where they were having problems. Also, in some patients, we can get better access to problems in their neck than we could without this procedure. If you look at this neck, I want to point out 2 things. One, the disc spaces slope downward. So the front is to the right, the back is to the left, okay? So the front is the right side. Look at the slope of the discs. They slope downward as you move forward. Now, if you think about how the body is made, at a certain point when we go down in the spine, we get to a point where we can no longer look up through the discs. When we're, as surgeons, operating on patients, we can usually get down between the 6th and 7th levels of the neck easily. It's hard to go below that because the collarbone and the breastbone begin to get in the way. It's just a limitation of the body. With this procedure, instead of going up through the disc space, we're going down through the bone. And so, instead of having to look upward as I had to at these levels, I was able in this patient to go all the way down here and get this done working downward. So it gives us better access to the lower part of the spine in the neck, and as I was able to employ here in this procedure. So how many patients have undergone this procedure? Well, in the earlier stages, in the freehand approach, as we were getting everything developed, and I think as other groups were also beginning to advance their thinking in this procedure, we were able to do over 100 patients freehand. We've done over 45 patients, and actually that may be now close to 50, with the transcorporal microdiscectomy guide and using the instrument set. And the last 15 patients now have undergone this procedure using our bone void filler, using the implant. So, does it last? Well, it seems to. I've looked at my earliest patient series, the ones before we started using the drill guide, before we started using the plug. And in that group of patients, as I'll show you in a minute, we have follow-up over 4 years on average, and it does seem to last. Additionally, other groups are reporting good outcomes in their work. I also would think that, at least at an intellectual level, removing the disc fragment but not the entire ruptured disc, removing the bone spur without removing the entire degenerated disc, when we can, in cases where we think that will work. Again, in the appropriate selected case, it should work because in the lumbar spine we can do it, and also in some cases in the neck we can also do a procedure coming in from the back if the ruptured disc fragment is ideally positioned. So there are some lines of evidence that would make one think it should work, and there are also some lines of evidence that would make one think it does work. Here's one of the lines of evidence that would suggest it probably does work. And this is, again, at follow-up at 50 months, so just over 4 years. When I look at my transcorporal microdiscectomy patients compared to some patients that I've done with single-level anterior cervical fusion, I've asked the question, all right, if these patients are failing, if ultimately this isn't working, how am I going to know it in my practice? Now, more recently, we have been collecting what we call standardized outcome measures. We're more rigidly tracking outcomes for patients, and this is a trend throughout medicine. But if I look back in my own experience as a physician in community practice, and earlier on, before I had started doing some of this research, we weren't getting standardized outcome measures on all patients as we are now. So if I look at non-standardized outcome measures as I've followed, and I ask the question, okay, if these patients are having problems, how are we going to know it? Well, one, they'll be coming back with symptoms of pain that is returning, and some of them will need additional surgery. So if I ask the question, am I doing surgery more often on my transcorporal microdiscectomy patients than on my cervical fusion patients? The answer is no. At a follow-up of over 4 years, my reoperation rate is 2% in either group. And I'm happy with that. In the literature, it runs somewhere in the neighborhood of 3 to 4%, so I'm happy with that result. Also, if these patients were having problems, I would likely be needing to get CTs or MRIs more frequently. Am I? No. 5% on my transcorporal microdiscectomy patients and 12% of my anterior cervical discectomy fusion patients. Also, am I getting physical therapy on these patients at a more frequent rate? And the answer is no. In about a third of patients in either group, at some point in that 4 years after the surgery, we've had to order physical therapy. And again, that may or may not have had anything to do with the initial presentation. It's just that, have we had to do physical therapy on these people at all for their neck? Now I am collecting standardized outcome measures on a more rigorous basis. The Neck Disability Index, or the NDI, is one way we have of measuring how well or poorly a person is doing. And 0 is perfect. You have no disability whatsoever. The upper limit on this scale is, now I want to say 30. As I'm thinking about it, I realize I didn't have that limit. And the upper limit of the scale here is 25. But I'm about 90% sure that it's 30 is the upper limit. So patients came in with an average neck disability index of about just around 21. And we were able, after the surgery, to bring that down, around to about the 4 and then down to about 3 level on this standardized scale. So more blue is more disability, less blue is less disability. We asked the question, are we taking care of their radiating pain? Or here I've called it arm pain just so it's simpler, but this really is shoulder, arm, and hand. I should probably label that differently. We follow this in a question that many of you have had to answer in the past. On a scale of 1 to 10, how bad's your pain? Pain is subjective, and this is one way for us to try to get a handle on how severe a person's pain is, or at least whether or not we're improving their pain control or not. These patients had arm pain that was 7.8 on that 10-point scale before the surgery, and we're able to get that down to about a 0.3. Most of these, and what this means on a practical level is that in this group of patients, most people are down to 0, but even if you have 1 or 2 or 3 in there, it'll kind of pull up the average to 0.3. When we ask the question about neck pain, we're able to bring that from about a 6.8 on average down to, I think it was 0.7 on latest follow-up. And so here I have before the surgery, 1 month after the surgery, 3 months after the surgery, and latest follow-up. Latest follow-up is anywhere from about 8 to 12 months for some patients, and for others it's as short as that 3-month follow-up. So, it's a mixed bag, but we're just past the mean follow-up of 6 months on this group. And then finally, a graph that I'm quite proud of, return to work. Now, this is on the 9 patients on whom I've done an isolated, this is a small number now, on the 9 patients on whom I've done a single level transcorporal microdiscectomy, so they did not get a fusion at an adjacent level. And of these patients, we were able to get 6 of the 9 back to work within 4 days. So 2/3 of this small group of patients were able to get back to work within 4 days. And again, with a fusion, that would be 4 to 8 weeks. With a disc replacement, it's often 4 to 6 weeks for patients. Some can't, in office workers, some people can get back earlier, but those are the published averages for the return to work time. So some patients shorter, some patients longer. And again, here we're able to get 2/3 of patients back to work this 2/3 of this small group back to work within 4 days. We're able to get all of them but one back within 14 days or 2 weeks. So let me show you a few examples and then I'll take some questions. This is just a sample case. A person had a soft disc herniation. We were able to get the fragment removed by doing this procedure, a TCMD. We were able to let them go home the same day, and this individual went back to work the next day. This is a case where, the point I wanted to make here is that this is a case at the 12-week mark, and actually I have a 1-year follow-up film I should have shown, but this is an earlier one at 12 weeks. And what we're seeing here, it may be hard to see, but if you look on the picture on the right, the plug is starting to dissolve, if you will, or being reabsorbed. The person's own bone grows into the beta tricalcium phosphate, and eventually it basically becomes a part of their own bone. And so this person did well. They did not have any pain come back. The beta tricalcium phosphate is reabsorbing as we'd want it to be. And also note that the height of the disc space at this early phase is not decreasing. Before I showed you a 6-month follow-up film and another group where the discs was starting to get shorter. This is an earlier time point, but we're not seeing that. Another case, this is one I think I showed you an x-ray on earlier. This was an individual who had narrowing at 3 different points. This one, for reasons I won't get into, I was able to do a transcorporal microdiscectomy on. The other ones I really couldn't. But again, we were able in this case to preserve motion at one of the levels, and instead of a 3-level fusion, this person had a 2-level fusion. And then finally here, once again, we were able to get to the lower pathology. So with this procedure, transcorporal microdiscectomy, we have flexibility. We're able to allow the patient to get back to work in days, not weeks or months. We're able to save the natural disc space and save natural motion. We may be able to reduce adjacent segment disease risk. Again, still an area of open investigation. We have a lot of questions about how real it is, a lot of questions about how best to avoid it, but if we're preserving motion at that level, we're hopeful that we're not even bringing in additional risk factor for adjacent segment disease to the extent that that's a real entity. Finally, in addition, we can use this either in standalone or we can use it alongside either a cervical fusion or an arthroplasty. And then, of course, accessibility to the lower part of the neck is enhanced. I will also mention that if a patient has this procedure, and let's say they have this at age 20 and at age 60 they have arthritis at that level in their neck and they need to have something done. They really haven't burned any bridges. It's all their own tissue, and we can always go back and do whatever procedure, 20, 30 years from now would be done, and they would not lose any future options. So thank you very much for coming and for your attention, and I'll take any questions people may have. Yes, sir. Your questions, it's fair to ask that of a physician. I think what's hard here is that I really don't know the details of your situation and what really could be done. I think what I would suggest, though, as a reasonable place to start, if your goal is to try to improve your mobility and to try to get away from your walker, a reasonable place to start would be to meet with a physical medicine and rehabilitation physician and see if they're able to help you get stronger and perhaps get away from the walker. That may or may not be possible. From a surgical standpoint, really if there is not a return of tumor, and hopefully for you there has not been, there really would not be anything surgically that I would be able to do to help, but I would suggest meeting with a rehab physician. At the Brain and Spine Center, Dr. Shelley Freimark is a physical medicine and rehabilitation physician we work with. And I know we have some materials at the back, and the office number there would allow you to get in touch with her if you have questions about that. No, the procedure can be done, in theory, the procedure certainly could be done at more than one level. I think when a physician's doing something novel, it's good to walk before you run. And so at this stage, we're being cautious. We certainly have designs on a double-barreled guide, for instance. So if there are bone spurs or disc problems on both sides, we could get to that. We haven't really started doing that because if there's anything that we have to learn, I want to, first I want to know that, and again, I want to walk before I run here. So in theory, could we do it at multiple levels? Yes. At this stage, honestly, I'd be very selective about offering that to anybody. So, which means, I guess, is a kind way of saying I probably wouldn't. I mean, I wouldn't say 6 months. I would certainly think, on the short end, a couple of weeks, and the longer end, by 6 weeks. Certainly within that time frame, I think you should have an idea about whether you're heading in the right direction, whether your symptoms are really beginning to abate. I'll also say that while over time, bone spurs, unfortunately, don't tend to get smaller, most people who have a disc herniation ultimately don't need surgery, and most of our patients we can treat effectively without the need for this. So again, I'll highlight, this was a talk about a minimally invasive surgery on the neck, but most patients who have a disc rupture as the primary problem ultimately we're able to treat without it. Yeah, for many patients who are not getting good response, especially with many low back and mid back problems and land-based physical therapy, for many but not all of those patients, physical therapy in a water environment. That's something that's obviously individual, that's from person to person determination, and I would encourage people to talk with their therapist. Yes, ma'am. Usually a reasonable place to start is with the primary physician, and what they will usually do is try some physical therapy. And if something of that sort, anti-inflammatory physical therapy, those are reasonable for you. Those things work, then you would not need to go farther. On the other hand, if you were to report to your primary physician this and you advise physical therapy, they considered anti-inflammatories and they may not be right for you. If you were to try those things and they were not successful, then it would be reasonable to consider getting an MRI done and considering either the reactivation or surgery depending on finding something wrong. But I would start with the primary physician. Short list, it's really something that ultimately a surgeon would need to determine. Training people in this technique, but there's still a pretty limited number of surgeons who are doing training. It's actually 2 days from now. We've done a number of other training sessions as well, but it would really be a surgeon who knows the technique. I think if, from the patient standpoint, I think first if you can take care of the problem without surgery, it's always great. That's not working, then I think it's reasonable to see someone who's knowledgeable in the broad array of techniques so that they can help you determine which one is best. When I can use this, I do, but cervical fusion and in some very selected cases, disc replacement are reasonable procedures that I do as well. And fundamentally, I mean, the brief version of what would make because we're preserving movement, we want to have a disc up front and also facet joints once the back is mounted, not discussing. But at the level of the motion, we need to make sure we have a disc on the facet joints. If a person has severely degenerated disc or severely degenerated facet joint, or if they're moving abnormally at that level, the spine is not stable, this is not a good procedure. If a person has severe narrowing around the spinal cord and severe narrowing from bone spurs affecting both of the nerve roots that lead at a pedal level, they're not a good candidate for this version of the procedure. I hope one day to be able to have variations of this available for other problems in the neck. But again, we need to walk before we run just to develop the spinal. And so what we're doing right now is really targeting problems where there's